Hello, hello, everyone. Good morning, good afternoon.
Hey, hi everyone. I'm Edward Chien from Rutgers University in the prosthodontic department. So today, the Young ITI Global Talk Series Agree to Disagree will kick off officially today with our dear friends from Switzerland to talk about this hot topic, resin-bonded fixed dental prosthesis versus dental implants. And it's a great honor for me to co-moderate with my dear friend Samir from the University of Bern on this hot topic. So Samir, tell me a little bit about your team, from Switzerland.
So, first of all, I want to thank the Young ITI so much for the invitation of Team Switzerland. We are very proud to take part in this great event called Agree to Disagree. I think we found a pretty interesting topic with a question that always arises when we have to replace an anterior tooth. So, is this ideally treated with a resin bonded bridge or a dental implant? And we have two guests here to discuss this topic, clearly from Switzerland. And we have, as we know, we may have different points of views from surgeons and from prosthodontists. We invited a prosthodontist from the University of Geneva. It's Duygu Karasan. There she is.
Hi, Duygu.
Hello, everyone. It's a pleasure to be here. Good to
Let
see
me
you
just
all.
quickly introduce Duygu. She's from the famous department of fixed prosthodontics in Geneva. So she's team member and faculty member of Irena Seiler's staff. And they are very well known that they work efficiently with resin bonded bridges. So clearly she will represent the treatment option of the resin bonded bridge. And Duygu, thank you that you accepted the invitation from the Young ITI, but also from Team Switzerland to represent the resin bonded bridges here.
Absolute honor for me too. I would like to thank for the invitation as well. And it's going to be fun, and I'm really looking forward to it.
So, since we have a prosthodontist, we need the counterpart, which is the oral surgeon. And we also invited a young gun from Switzerland here called Clemens Raabe, senior lecturer at the University of Bern, so the dental school where I am. And he was trained by Danny Buser and now by Vivian Chapuis. So he has dived deeply into the Bernese tradition of implant placement. Yeah, and clearly he will opt for placing the implant in the anterior side. And now we will see his arguments for that. Clemens, welcome, and also a big thank you that you accepted our invitation. We cannot hear you.
Thank you very much, Samir, and a warm-hearted welcome to all of you guys.
Great. So
let's the presentation with Duygu's side of the resin bonded fixed dental prosthesis. So Duygu, the floor is yours.
Thank you. Let's begin then. Hello, everyone, and thanks for tuning in for the first Agree to Disagree session. Today, we are sharing this session with Clemens, Samir, and Eddie. My name is Duygu Karasan, and I am working in University of Geneva in Division of Fixed Prosthodontics and Biomaterials. I am a former ITI scholar and also an ITI fellow, and I'm quite involved in ITI since my graduation from dental school. So it is quite nice to be here with you today to talk about a topic that we really like in Geneva, resin-bonded bridges. And I'm going to compare a bit resin-bonded bridges to single implant therapy and single missing tooth gaps in the aesthetic zone. As you know, resin-bonded bridges is considered as a provisional treatment option for some dentists. And for some, it is a concept that they have heard of but never applied. But for us, it is a primary treatment option for some certain clinical situations. And the reason that we see it as a very essential part of our clinical practice is because they are minimally invasive and cost effective. So, but there are critical aspects for the resin-bonded bridges to be considered before starting the treatment, or when you're deciding which material to use, or if you need to prep or not. And those little details is quite important to have a successful result with these type of restorations. Let's start with a case that is quite interesting and also complicated, because Marisol is a dentist and she was 37 years old at the time of the treatment. She had repetitive trauma to her tooth number 12 as a child while she was practicing with hand pedals. And she had endo treatment, retreatment, and eventually, age of 37, she had a huge radiolucency at the distal side of the tooth number 12, and a deep pocket, 12 millimeter of periodontal pocket at the distal aspect of tooth number 12. And even though she was quite attached to that tooth, she was convinced that it is not possible to save this tooth and it needs to be extracted due to a vertical fracture. And her first question, of course, was, what are my treatment options? And as you imagine, there are mainly 4 options to offer in these kind of situations. And the first 2 are the conventional options that we can already eliminate for her case. And that leaves us only 2 treatment options: an implant crown or a resin-bonded bridge for the missing number 12. And her second question was, what are the evidence for these treatment options? So let's go through the evidence through the systematic reviews published about this topic. And we can see that the survival rate for these 2 treatment options are quite similar to each other, and they are both clinically acceptable. But it comes a little bit more interesting when we look into the complication rates. We see that they both have some debonding problems, which we expect actually for resin-bonded bridges, because they are prone to have debonding, but it is easy to rebond, and this is a easily solvable problem. It becomes even more interesting when we look into the biological complications, because we know that the biological complication is something that we really don't want to have with dental implants, but on the other hand, we often have them, and it's quite hard to avoid it in the long term. When we have a periimplantitis in the aesthetic area, the result or the problem, the complication can go very bad, and the solution can be very difficult, and the patient can be frustrated. On the other hand, when we look at the resin-bonded bridges, the biological complications are very limited, like caries maybe, and very low actually incidence, and these are quite easy to solve problems. After looking at the literature, we can summarize the advantages of the resin-bonded bridges over dental implants, and we can say that they are clinically acceptable, they have clinically acceptable survival and complication rates. They have very little risk for the catastrophic complications. When we have a complication, it is easy to solve, and this is one thing that we really want from a treatment as a dentist. And they have significantly reduced biological complications. Additional to those, we know that they are minimally invasive, they require minimal preparation, and they are cost effective, they require shorter treatment time, and very important thing, they are indicated for the growing patients, for the young individuals. So for Marisol's case, it was an easy actually decision for us in those cases. After the extraction, it's important to preserve the soft and hard tissues at the pontic area, and which preservation is really highly recommended. And later on, a soft tissue conditioning at the pontic area is quite crucial to achieve a good aesthetics for the final restoration. And in the hands of a talented technician, you can see that we can achieve a really harmonious, nice looking restoration, cleansable, and even after a 4-year follow-up or even more, you can see that it remains healthy and very respective to the surrounding tissues, and with little or no complications, it can remain in the mouth as a definitive treatment. So, what are those critical aspects that we have to evaluate before starting the treatment with resin-bonded bridges? We have to know their indications and contraindications. We said that they're indicated in the anterior region, but we have to have an eligible neighboring tooth, adjacent tooth, and abutment tooth. What does it mean, an eligible? It means that we need to have a good adhesive surface that is that we have enamel, and at the same time, we need to have a periodontally healthy abutment tooth. These are two critical aspects, and they're indicated in young individuals that are still growing, and adults with a request of having shorter treatments or less costly treatments, less invasive treatments. Also, it is indicated when the adults are having high risk with the implant treatments, which can be general or local risk factors. But we have to be really careful of the mesiodistal space that we have for the resin-bonded bridge. If a diastema is required because of the aesthetic reasons, then they're contraindicated. Or if the overjet and overbite limited, and we cannot achieve sufficient material thickness, then they're also not indicated. Other than that, when we are doing a resin-bonded bridge, we have to consider what type of design we are going to do. And this has been discussed in the literature for some time now. And now we know that we have to go for a one-wing design rather than two-wing designs. The clinical studies showed clearly that one-wing design is superior to the two-wing. And we also know that for the material selection, it is rather to go for monolithic restorations that were made of either lithium disilicate or zirconia. And as for the cementation, adhesive cementation is obligatory, of course, and correct surface treatment, primer and resin cement selection is critical to achieve a successful result and avoid the repetitive debondings. And let's look at a case that is quite clear for us to make the decision for resin-bonded bridge. Two canines that has very nice adhesive surface, enamel surface, and initial soft tissue grafting to improve the pontic areas. And later on, after soft tissue grafting, the pontic area has to be conditioned with the provisional, in addition to the provisional, gradually, and to achieve a nice emergence profile of the restoration and the harmony and cleansability. This is quite critical. And later on, the technician is going to design digitally and produce the restoration either from zirconia or lithium disilicate, and the minimal and the micro veneering is also recommended to achieve a nice aesthetics. And as I mentioned, adhesive protocol and adhesive cementation is quite critical. And later on, you can see that a nice harmonious result with resin-bonded bridges is quite easy to achieve. And the patient can clean easily. And in young individuals, this can be used with comfort and then with reduced complications. And with this, I would like to finish, and I'm looking forward to the heated discussions.
Wow, Duygu, top class presentation as expected. Yeah, thank you so much. Thank you so much for that. But to have later on a good base for the discussion, let's now listen to the surgical view, because I think this might be a little different from your point of view. So, Clemens, what do you have to say how to treat an anterior missing tooth? Let's see your video.
How to deal with single tooth gaps, screwing or gluing. My name is Clemens Raabe and I'm excited to explore these challenging clinical scenarios alongside you. In the present case, we encounter a young female seeking a durable solution for her missing tooth. But how can we reliably achieve both satisfying aesthetic and functional outcomes in intricate cases such as this? Should we opt for dental implants or resin-bonded fixed dental prosthesis? Unfortunately, there isn't a one-fits-all solution. It's up to us as clinicians to assess each individual case carefully and determine the optimal treatment strategy. In this specific case, we opted for dental implant therapy, a choice that has been demonstrated consistent high treatment success if evidence-based surgical protocols and regenerative procedures using well-investigated biomaterials are applied. By that, a pleasing hard and soft tissue architecture are rebuilt, and together with a correct three-dimensional implant position, a solid fundament for a pleasing restoration is given. As you are aware, we categorize implant placement into 4 types, depending on the time of the tooth extraction. The decision on which implant placement protocol to use depends on specific patient and site-related factors, considering both the pros and cons for each individual case. Each of the implant placement protocols can provide high treatment success if used appropriately. However, as there are so much interesting facts about this field which could easily fill another lecture, I won't go in detail at this moment. But I may tell you what greatly assists me in my everyday clinical practice to correctly classify my case's treatment complexity. The ITI SAC assessment tool is a systematic decision management tool rooted in well-founded evidence. It proves invaluable for assessing the complexity of treatment both during the surgical and prosthodontic phases and significantly contributes to improving treatment results. The individual treatment protocols also have an influence on the 3D implant position, a crucial factor for aesthetic outcomes. In an immediate implant protocol and early implant protocol, the implant was placed in an extraction or extraction-like socket. Whilst in late implant placement protocols, the implant was placed in a healed alveolar ridge. Preclinical and clinical studies have proven that the alveolar ridge morphology has a strong influence on implant placement accuracy. In the right-hand figure you can see the planned implant position in black and the final implant position in yellow and orange. As you can see, the implants, orange and yellow, tend to deviate to the center of the socket, as this is the zone of less resistance during implant osteotomy and placement. Significantly higher crestal, apical and angular positional deviations were found in extraction sockets, displayed in light blue, compared to healed alveolar ridge morphologies displayed in dark blue. However, if these factors are well controlled, the long-term data for dental implant therapy yields survival rates of over 95% as based on numerous studies. But from a patient's perspective, we should also take the performance of the supraconstruction into account, ending up in an almost 90% survival rate. In the past, dental implant therapy was not feasible in certain clinical scenarios, like limited mesiodistal spaces in case of small teeth. Luckily, resin-bonded fixed dental prosthesis could be frequently applied in these cases to satisfy the patient's needs. However, with the advancements of implant materials and surface properties, dental implants might also be used in these indications nowadays. Not only narrow implant diameters have been introduced, but also implant macro designs evolved in the past decade. The classic parallel-walled implants still work perfectly in my hands in most of the cases and have the benefit of insertion depth flexibility. However, in cases where primary implant stability may be questionable, tapered implant designs are beneficial. Self-cutting properties of the threads allow for under-preparation of the implant osteotomy and high insertion torques. Recently, tapered implants with more aggressive thread designs were released and might provide sufficient primary implant stability even for immediate loading protocols. With the increase in options, dental implants may be utilized to replace all teeth, regardless if it's a central incisor or canine where increased forces to guidance in dynamic occlusion needs to be considered, or if it's a lateral maxillary or mandibular incisor with limited mesiodistal space. But how about comparing both dental implant and resin-bonded fixed dental prosthesis with each other? Examining the literature, particularly long-term data, reveals less favorable outcomes for resin-bonded fixed dental prosthesis. Initial studies suggested a 65% survival rate, but a recent systematic review by Danny Thoma showed an improvement to 82.9%. This increase most likely can be attributed to advancements in adhesive techniques, ceramics, and strict case selection protocols. Beyond survival rates, the consideration of complication ratios is imperative. Common single implant crown complications include a 3 to 9% loss of retention, particularly prominent in older publications looking at external implant abutment connections and angulated implants. The utilization of modern implant connections and precise implant placement aids in avoiding these issues. Nonetheless, the challenge of retention loss persists in resin-bonded fixed dental prosthesis, with debonding rates reaching 15% after 5 years. While these reconstructions can be re-cemented, it's crucial to note that failure rates tend to rise with each rebonding, potentially leading to patient dissatisfaction. The second most prevalent concern is chipping of veneering material, which varies based on the material type rather than the reconstruction method. When it comes to selecting the ideal approach for addressing single tooth gaps, the path forward isn't always straightforward. My paramount consideration as I evaluate patient-centered treatment options is to secure a solution that guarantees lasting success. In pursuit of this objective, it is important to note that a significant portion of my patients are well suited for implant treatment. However, it's equally important to acknowledge that resin-bonded fixed dental prostheses encounter limitations in certain clinical scenarios. Take, for instance, the precise location of the single tooth gap. Resin-bonded fixed dental prosthesis may yield satisfactory outcomes in the anterior zone, yet prove less effective in posterior areas exposed to robust bite forces. Yet let's dive deeper into the contributing factors that might amplify the potential for failure in case of resin-bonded fixed dental prosthesis. Today I examined this young female in our clinic, and I thought about what to do if she would lose a central incisor. So let's simulate the tooth loss in order to assess the case more in detail. We clearly can see that this patient had an increased overbite, also showing contact in static occlusion. And if we bring the patient into function, there's also anterior guidance in the dynamic occlusion, causing massive forces on the resin-bonded FDP. From a lateral perspective, there's a tendency for retroinclination of the central incisors, indicating occlusal contacts in static occlusion, which could be solved either using ortho treatment or grinding down the enamel on the palatal surface of the abutment teeth. Another limitation are clenching patients, as tooth grinding habits are associated with increased debonding rates, or the restoration status of the abutment teeth, as a sufficient amount of enamel is necessary to bond the retainer. So all in all, I favor dental implants more frequently, as they are suitable to a broader range of indications and provide excellent aesthetic and functional long-term outcomes. but it's crucial to understand that handling implant treatments can be complex. It requires skilled professionals who are committed to learning and improving to achieve the best possible outcomes.
Once again, great presentation. I think you set the base on a very high level for our discussion now, guys. Thank you for that, for representing also Team Switzerland on this high level. Yeah, thank you.
And you both have controlled the time super nicely, so you gave us plenty of time to go ahead with our discussion. And honestly speaking, I'm quite sold on both, treatment options. So then the question will come to both of you is that, my first question that I would really like to ask you both is that, is there like the cases you've showed, the age of the patient, is the age of the patient a consideration for either options, because you two didn't really touch a base on that. So then if you can discuss a little bit like, how would you treatment plan for a young adult versus a patient that's slightly older in this mid 30s, 40s, or later on, like in the patient's life around like 70s or 80s, down the road? How would you plan these cases, Duygu, or how would you plan these cases, Clemens?
So maybe I go first. It is quite clear that age is one of the most important factors that we consider when we are thinking about a single tooth gap in the aesthetic area. And very often those patients who are missing is, there is a gap in the anterior zone. It is likely that they have a genesis and that there is a congenitally missing lateral incisor or so. And in those cases, it's quite clear that we cannot place implants in the growing patients, which we know that infraposition of the implant is quite likely to happen. And this is why resin-bonded bridges are indicated primarily for these cases, of course. And age is a very important contributing factor. Absolutely.
That's absolutely right, Duygu. I totally agree on that. Absolutely, if the patient is really young, we need to go for a resin-bonded bridge. But then there is this certain time frame from 20 to 25 or 30 years when it also comes to dental implant placement, right? And what really helps when considering the age of the patient in this critical interval is contacting the ortho, like the orthodontists, because they can foresee the first growth that we can actually anticipate for the future based on the radiology take from hands, for instance, right? And we know that short phase phenotypes that they stop growing earlier.
Clemens, you are a little hard to understand. I don't know.
Okay. Is it too
Yeah, now it's better. Lean forward to your computer, I think.
Okay, I'm so sorry about that. So what I actually said was it's crucial to import the orthodontists, right? Because they can help you in evaluating the growth that is anticipated for the future. So if you're in the critical time frame between 20 and 30 years, they can have a look on their x-rays and anticipate how much vertical growth they actually expect for the future, and it helps in timing of implant procedures.
So where's your comfort zone?
Yeah.
Sorry. So I'm just wondering, so Clemens, at what age is your comfort zone to start placing implants for young adults?
Generally speaking, over 25 years. If it's younger, then I'm more suspect, and I have a higher tendency to speak that up with my orthodontist.
May I interfere here, because I think it's a very interesting discussion here. So Clemens, you gave an age. Duygu, you avoided to give an age because everybody is saying, yeah, in a young patient I would not do that. But what is considered
but I
young?
Said, still growing patient. And,
still growing patient.
Yeah.
But what is a still growing patient?
There's a very interesting aspect there, right? Because we have more and more. We have those cases, and we have more and more literature coming out that actually the growth is ongoing over the years, the mesialization of the teeth are always changing position. And when we place a posterior implant, this mesialization and having gap between the implant and the tooth is not a big issue. So we can solve it easily with a little restoration and close the gap or redo the restoration and so on. But when we have ongoing growth in the anterior area, and we see this likely even implants placed in young individuals, and I'm referring to patients even 25 or 30, we still might have some infraposition of the implant after a certain time. And this was one of the reviews in the AO consensus conference, I think, the previous one. This is why we are collaborating a lot with the ortho division, and we discuss this a lot. What is the limit to put for the implant? And it is quite unclear, I must say. I cannot give a number.
Let me just explain you a little bit my point of view. First of all, let me name two studies. There's a nice study by Daftari called A Lifelong Craniofacial Growth that shows that the craniofacial growth, especially in the mid-phase, is never over. Yeah, and also a nice study by Julia Wittneben and Urs Belzer, where they show this incisal step formation even in older patients. So referring to that, now coming to you, Clemens, I feel even uncomfortable with an implant in a 30-year-old patient because it's not only this positioning that changes over time. For me, when we look into implants, yeah, when we consider long-term outcomes, 30 years. When an implant lasts 30 years, we are so happy. Now, when I see an implant that has been placed 30 years ago, I'm so happy, but I see them rarely. Yeah. And now what happens if you place an implant in a 25-year-old patient, anterior side, 30 years later, if the implant fails, the patient is 55 years old. So in the middle of his life or her life. Yeah, and the aesthetic zone is let's say, a little bit deliberate for the patients. Yeah, and I always have a little trouble placing implants at such an early time point. What can you do if an implant fails? Yeah, after 30 years, what do you expect? What kind of bony defect? What is your treatment then after this 30 years?
First of all, I absolutely agree. I mean, we need to place dental implants at the latest possible time point, right? Especially if we have alternative treatment options. So probably I just was basing my answer on a different point of view from the initial question. But what happens if we lose the implant, right? So there are two major points to lose an implant. First of all, there's aseptic disintegration that might take place, right? And those are sites which regenerate quite good because they have a four-wall defect. And in these patients, I think it's not a big of a deal to get back in for another implant placement procedure after 4 months of healing or 6 months of healing. It's a little bit different for the patients who developed peri-implantitis, and there we have to clearly find or identify risk factors that contribute to this peri-implant infection, right? So first of all, classifying the patient again, is another implant placement actually indicated, or do we have risk factors contributing to the implant loss due to infections? And if it's possible, then we need to discuss with the patient if a reconstruction of the alveolar ridge, which is always a bit more invasive, is their favorite treatment option. So, but if
you have to lean a little bit more forward.
Still, hey, I'm already crawling into my computer.
You're far away. Still, we see not the complete face on the screen. So,
okay. So it depends on the morphology of the defect, right? Because this is the main consideration when it comes to method of reconstruction we're actually looking at.
I think you just said something that made me really happy, and I think that is something we can all agree on. If we can, we place the implant at the latest time point as possible regarding patient's age. Yeah, but we know it's not an ideal world. Sometimes we have to place the implant earlier. Yeah, I agree on that. But I think as a common sense, and let's let me ask you, can we agree on that? Placing the implant at latest as possible is the way to go, if we have alternative options.
Yes.
I'm fine with that.
Great. Duygu, now I have, Clemens was pretty much elaborating on that. Now I have an interesting question for you. You showed these mean survival rates after 10 years of around 85%, but we know that there is a very broad range. So if people doing the resin bonded bridge as well, we have very good long-term survival rates after 10 years. And we also have very low survival rates for those studies that did not perform so well. So obviously you guys in Geneva, you have some very nice outcomes. So can you tell me, what is the Geneva secret that everybody should apply to get these nice outcomes with resin bonded bridges that you have?
Yeah. So I think that's one of the critical questions, and I was when I was presenting, I was saying that it is quite crucial to really correctly choose the cases and follow the correct steps in some certain aspects. The reason I'm saying that, because there is a kind of a process in learning how to do resin bonded bridges, and Professor Karen has worked on it a lot, and clinical data is coming from Germany as well. But when you look at the systematic reviews, you see that the earlier systematic reviews are showing relatively lower results compared to the more recent ones. And Clemens also pointed out in his lecture that it is due to the material science. The adhesion has evolved and actually become better. And at the same time, the materials that we are using are completely different than the materials that was used in the studies that was included in this review from TOMA 2012. So mainly the metal ceramic resin bonded bridges, they're all veneered and prone to chipping and prone to debonding. And the bonding system that was used in those studies were quite heterogeneous and not really ideal. So now, more or less, we really know how to do a correct resin bonded bridge. And if you look at the more recent actual results, you see that the complication rate, even the debonding, has quite decreased. And at the same time, we see different complication rates for different material types. This is why I pointed out two main materials we recommend. One is lithium disilicate, and the other one is zirconia. And when I'm saying this, I am always now talking about the anterior resin bonded bridges and not posterior resin bonded bridges. And posterior includes the premolars as well. So we have a good documentation and good clinical outcomes for the anterior resin bonded bridges, but not for the posterior. They are significantly lower, the clinical outcomes and the survival rates and the complication rates, significantly unfavorable compared to the anterior ones. So if we focus on the anterior resin bonded bridges, we can say that the main two material alternatives are the lithium disilicate and zirconia, and we use them as possible, as much as monolithic as possible as. And if we need some veneering for some aesthetic reasons, then we keep it micro veneered and to 0.5 millimeter, as we defined in the previous EAO consensus conference. And if you respect these aspects, then you would avoid the chipping problem that was published quite, one of the most frequent complications for resin bonded bridges. And apart from this, you choose the correct material, but of course you have to choose the correct case, right? You cannot do resin bonded bridge in every situation. That was pointed out clearly. The space, mesiodistal space, has to be allowing to do a single crown and a single pontic, and we cannot put diastemas to resin bonded bridges, at least on the connector side. And other than that, the overjet and overbite has to be sufficient. Because we cannot do extensive preparation for resin bonded bridges. We want to cement on enamel, so we have to remain on the enamel even when we are doing the preparation. This gives us quite actually
clear guideline how to choose the cases for resin-bonded bridges, right? So you need to have enough overjet and overbite. You need to have a mesiodistal space that is not extensive and that is not requiring, from aesthetic reasons, a diastema. And other than that, we have to have a good abutment tooth next to the edentulous space. So this is why we actually can limit the indications for the resin-bonded bridge to the lateral incisors, upper and lower, or the central incisors in the lower jaw. And also we can include in some selected cases missing central incisors, because the tooth next to it is going to serve as an abutment tooth, and the adhesion surface has to be enough. So it is rather a canine or a central incisor that will serve as an abutment tooth. Other than that, it is important that the tooth has to be periodontally healthy, right? So, but the young individuals that we are talking about are mainly covering all those prerequisites. So, and if you're also having a patient coming out of ortho treatment, you can also, distribute the spaces or arrange the occlusion according to your treatment plan, and so on. And for the cementation, if you are wondering, because this is very critical. Adhesive cementation is important, and you have to do the surface treatment on the piece, on the restoration, and on the tooth according to the material that you're using. And we always use an MDP contained resin cement and a compatible primer for the adhesive cementation. These are the main aspects. And then actually, if it fails, then you always can do an implant. And if imagine that you take.
Duygu, I don't want to hear you're using an MDP containing cement. What is the cement that you're actually using now? Help us out here.
Okay, so we use Panavia V5 or 21.
V5.
Panavia 21 is a chemical polymerizing cement that is completely chemical cement, resin cement, and both of them are containing MDP, and they have their own compatible primers, which is clear fill, and we also combine it with that one. This is what we obtain good results, and this is the cement that was used for the studies that published these successful treatment outcomes, and this is what we go on using here.
For zirconia, isn't it?
For zirconia and for also for lithium disilicate. So.
Okay, also for lithium disilicate. Perfect.
Mm-hmm.
Well, then let me ask Clemens for a different question. Based on what Duygu just mentioned, I see there's quite a bit of a limitation of what resin-bonded bridges can do as well, especially in what the cases that you have showed. The single central. I think there's still the comfort zone of the prosthodontist to try to do a cantilever for a single central be very, very difficult. So then, would the implant solution be the better solution in this case? What do you think about that? Like if a patient comes in regularly with a missing central, even a young patient, would you tell the patient if you ask the patient to go for a resin-bonded solution, or would you say that, a single implant will do the job?
Well, I think Duygu actually showed it quite nice in one of her cases, right? We have 4 different types of procedures that we can apply for those patients. And none of them is actually willed to go for removable partial denture, and the least of them have actually destroyed abutment teeth that we can go for a conventional bridge, right? So we are ending up with the fixed, like resin-bonded fixed prosthesis, or we end up with the dental implant. And now it's about looking at all those factors that Duygu just described, right? Actually indicating the resin-bonded bridge. And if they are not fulfilled, if we have contraindications for that, then the dental implant would be our last option to fulfill the patient's needs, right? But if you would go for a resin-bonded bridge, and I think you showed that quite nicely, Duygu, is controlling the time point of tooth extraction and actually go for alveolar ridge preservation. Because if you miss doing that, and the resin-bonded bridge will fail in the long term, then your alveolar ridge will have altered massively. And the fundament we have for dental implant placement 10 years down the road will be really, really unfavorable, right?
Thank you for pointing that out. I think that's a very important point to not forget about alveolar ridge preservation. And Duygu, you showed it nicely. Also for optimization of the soft tissues. Yeah. Using connective tissue grafts, because the pontic site has to be as ideal as possible that it's cleansable, which is also very important for the resin-bonded bridge.
So Clemens, would you say the soft tissue management for the single implant is slightly easier in your situation comparing to a resin-bonded fixed dental prosthesis?
It's in every case more delicate, I would say, right?
More delicate, yeah.
Absolutely. There are a lot of factors contributing to the aesthetic outcome of an implant procedure, right? One is time point of implant placement. Then we also have a position of the implant, right? And implant malpositions highly contribute to aesthetic failures, like a buccal implant malposition or facial malangulation, choosing the wrong implant diameter, wrong vertical position of the implant. And therefore, you really need to have a good clinician placing the dental implant in order that the prosthodontist also has a fundament to work with, to play with soft tissues that they can push and bring into the right position.
Absolutely.
Clemens, there was something very interesting in your presentation that was not mandatorily related to the question resin-bonded bridge or implant, but you showed a study by Fabrice Dulla. Yeah, that showed that you have deviations in the extraction site. So when you go for immediate implant placement, which is a protocol that is usually applied in the anterior sites, this immediate implant placement, you still have deviations of 1.5 millimeters when you use computer-assisted implant surgery. So you're not better than with freehand surgery, but the ITI recommends, especially in those cases, immediate implant placement, anterior sites to use guided surgery. So showing that study, and you were part of the study, how do you see that situation now? Would you go for immediate implant placement for computer-assisted surgery that is not more accurate than freehand surgery in the extraction socket?
Well, it's a really, really interesting question. And first of all, please let me point out that if you are doing a proper case selection, I think that immediate implant placement is roughly indicated in less than 10% of all cases. And I know that worldwide, this treatment protocol is applied way more often, okay? But there are so many prerequisites that need to be fulfilled or inclusion criteria that, at least in my patient cohort, it's quite hard to find a patient where it's actually really indicated. So that first of all. Second of all, you know, I really like computer-assisted implant placement, but I also like free-handed implant placement. And my critical issue is that I just mistrust my computer assistants, right? And this study actually should highlight that if we blindly follow the computer-assisted implant placement procedure, we will end up somehow in a malposition. And by that, knowing that right now that we have a higher risk for implant malposition in extraction sockets, we can, at an early stage of implant osteotomy already, check our comfort zones, danger zones, which were described by Orsales and Danny Boozer back in 2004 and still apply today, in order to avoid any malpositioning. So it's beneficial if you do your first implant osteotomy in a guided manner, that you take your depth gauge, that you check it thoroughly, and if it's not in the position you've intended to be, then you need to correct it in a free-handed manner, right? So the fallback option of computer-assisted implant placement is always the free-handed technique, and the surgeon should be capable to apply both techniques in his patient.
Very well framed. Beautiful, Clemens.
Thank you.
Thank you for that. We don't have too much time looking here at the clock, but I have a very important question that I would like to ask both of you now after your presentations. Yeah, and I want you to answer it rather quickly. What would you choose if you lose now a single anterior tooth in the upper jaw yourself? You're both in the critical age where we don't know, have you grown completely? Are you still growing? So what would be your treatment of choice? Let's start, ladies first, with Duygu.
Absolutely resin-bonded bridge. Absolutely.
Okay.
Because I mean, our point is if it is indicated, all those parameters are set, and then we know that we can do it, then our primary option is more or less always resin-bonded bridge. There are one aspect of it, because we know that resin-bonded bridge is not going to cause anything catastrophic. So at any time point, we can always have the chance to do again the implant. And any complication with resin-bonded bridge can be solved easily. That is not going to cause big aesthetic issues and so on. And that this is like the core of the resin-bonded bridges, because the aspect that the idea of having an implant, myself, probably the biggest fear would be having peri-implantitis, I think, right? And then what do you do after 30 years, as you pointed out, Samir?
Okay.
Do I want at the age of 60s to have a treatment that might really be complicated, or can I push having implants as much as possible or not? I think the answer for me is quite clear. It's a resin-bonded bridge.
Yeah, you're a prosthodontist. I expected nothing else from you. So, but Clemens, your answer is going to be pretty interesting.
Yeah, absolutely. And I hope that everybody agrees on that, because if I could go for the best option of alveolar ridge preservation, which is from my point of view a root retention procedure, so let's say I have a horizontal root fracture, right? Then I wouldn't extract the root, which is still in my jaw, but I would go for the resin-bonded bridge. And by having the root retained in my jaw for the next 20 to 30 years, and I might end up with having some debonding issues, then I could still extract the root at a later stage and have all options for all implant placement protocols in my hands. And by that, it's most flexibility for the long-term perspective.
So maybe it's not having either a resin-bonded bridge or an implant, but it's rather having maybe first a resin-bonded bridge and at a later time point the implant in the same patient, huh?
Absolutely.
Yeah.
Beautiful. This is a beautiful outcome of the discussion, I think.
Yeah.
Eddie, what do you think?
I mean, for myself, I think, of course, as a prosthodontist, I'm leaning towards what Hugo just mentioned. So I think that's also unfair to ask me at all. But I do get Clemens' scenario as well, is that eventually, I think for cleansability, not everyone knows how to clean the resin-bonded bridges as nicely as just cleaning a single implant as well. So then I think for some of our patients, for cleansability, they may choose for the single implants instead of the resin-bonded bridges. But for aesthetic purposes, if as a prosthodontist, if we can develop the soft tissue with the ovate contact nicely, I think we can also have a very nice aesthetic outcome for younger adults and even to older adults as well. So, of course, for myself, I lean more towards resin-bonded bridges. But for some different scenarios, I would still suggest the patient for single implants, and especially for the cleansability issue. And how about yourself, Samir? If you lose your central, what will you do?
You look. For me, clear. Yeah. I have a bite situation that is easy, so I would go for a resin-bonded bridge. But let me just go step aside for Clemens, because the setup here is not fair. We have 3 prosthodontists and 1 surgeon, and it's not only Clemens who has to defend the implant, because we all know, that's what I wanted to say. We don't have always this ideal world that I was just like saying, let's put first the resin-bonded bridge and the implant at a later stage. Yeah, we have the situation, case selection, we mentioned it. We have sometimes the situation that we have to place the implant as the first option and not as the second option after the resin-bonded bridge. So I think the secret is to evaluate carefully both treatment options, to discuss everything with the patients, and something that may be interesting for the ITI, developing something like a decision tree, when to do ideally an implant, when to do a resin bonded bridge, that would be something very nice.
Absolutely.
I
Totally agree. Samir.
Great. Guys, I think our time is more or less over for the discussion, but we still have something left, Eddie. Do you want to tell us what we have left?
So in May 2024, in Singapore, we're going to have this Young ITI Day, the first one ever, a pre-congress and at World Symposium. So you can see it's on the 8th of May, 2024, Singapore. So scan the QR code, as you can see down at the screen, and you can get a link. Register as early as possible so you get the nice discount for students, for residents, etc. And we have a full day program of the World Series final. And at the same time, we'll have 3 sessions of the Agree to Disagree, like what we're having right now, but live. So this is our first one, and we're going to also move it slowly towards the World Symposium. And we're also going to have 3 keynote speakers, and our first opening keynote speaker will be actually Samir, here to talk about, patient management from young to old adults. And later on, we also have Sasada from Japan and also Teresa Chenting-san from Taiwan to end the Young ITI Day at World Symposium. So register and follow us on YouTube, on Instagram, and then share this amazing Agree to Disagree pilots series. And then the next series will be in 2 weeks' time with Team USA.
Nice.
So I hope
Great.
Nice.
Episode, and we'll see you soon again live with Team USA.
Thank you once again.
Thank you.
To
Thank
every
you all
one
for
of you.
listening.
It was a pleasure to work with you on this project, and see you soon, guys.
Bye-bye.
Bye-bye.
Have a nice
Bye.
afternoon.
Singapore.